thank you, Dr. Ashad, Dr. Harshali, for this invitation. After the first two great retina talks, I hope I can do some justice and you also can learn something how I learned from these two cases which challenge my practice. So as you know, complex cases often push surgeons beyond the conventional algorithms. Dr. Mahesh just beautifully said that. And these scenarios not only, test your technical skill and judgment, but also, redefine, evolve the standards in practice, like how Dr. Vishali told us about her experience with ocular TB. So this is this is the first case. So this was a 75-year-old male, one-eyed patient. Right eye vision was 6/9, left eye was 6/60. And you can see there on the OCT, the presence of a vitromacular traction there. And then just beside, the line scan of through the fovea, you also get to see like a bump in the RP, like a shallow RP elevation. So, and the left eye was a scarred CNV and vision was poor in that eye. And then I just kept the patient on follow-up. So this is after 1 year, the vision is still 6/9 in the right eye. And then again, you have a VMT now, which is slowly going into a lamellar hole formation over there. But since vision is good, I did not do anything. And there's also now the RP elevation is also slightly increasing in size. So there's subclinical in MNV probably, and the area is increasing. Now the question here is, do you treat these, subclinical MNVs? So that was the question there. So I got an OCT angiography done just to see, but I did not get anything conclusive, probably because it's like too early. The area of the choriocapillaris region just revealed somewhat like a projection artifact of the PED, but did not reveal a network as such. And there's no network in the outer retina also, the segmentation. So then I just kept follow-up, and then 6 months later, he comes with drop in vision. Now his vision is dropped to 6/18 in the right eye. And now the lamellar hole has progressed into a full thickness macular hole. And now the subclinical MNV has also started exudating, and it's become a macular neovascularization. And when you do the OCT angiography, other than the macular hole, you also get to see a network in the choriocapillaris slab as well as a network in the outer retina. So that's the 6 mm scan, and you get the network very beautifully in the 3 mm OCT angiography scan, what you see there. Now, after the dilemma here was, should we go in for vitrectomy first or should we go in for intravitreal anti-VEGF injection first? So after discussing with the patient, we decided to, give intravitreal injection of faricimab. Why faricimab? A better perspective for better treatment outcomes in neovascular AMD. So the advantage of faricimab over the other molecules is the fact that it acts on not on the VEGF-A, but also on the Ang2. And the Ang2 is the one which helps in stabilization of these abnormal blood vessels. So in head-to-head versus aflibercept, they have found that the reduction in the central subfield thickness is better, as well as a reduction that 77% of the patients have reduced retinal fluid when compared to aflibercept, especially with Vabysmo. And at 4 weeks of, monthly injection intervals, 75% of the patient had completely dry macula as compared to aflibercept. And what about the long term? When long term at 2 years, around approximately 80%, around 78% of the patients had complete drying of the macula, and also you could have extended the interval of faricimab to 4 months. So the patients have a longer treatment interval with faricimab. So coming back to our case, so this was now finally the full thickness macular hole is again increasing in size there. Some stage 1, it's gone to stage 2. And again, you have the MNV. So I gave him 2 doses of faricimab, and you can beautifully see the CNV has regressed, but there is still the aspect of the macular hole which is there. His vision has not improved. I told him we'll take 1 more injection and then we'll go for surgery, but he said, no, I cannot see anything. So I said, okay, let's go ahead. And we did off the macular hole surgery, conventional peel, because the hole is small in size. And you can see after conventional peeling itself and closed under SF6 gas, and the hole is closed, and after 1 month of the macular hole surgery, I repeated 1 more dose of injection faricimab, and his vision is back to 6/9, and there is regression of the CNV. Now the only question is, he requires at least a monthly or a 2 monthly or a 3 monthly follow-up, and I've told him lifelong follow-up, because any time the CNV can regress. So now the question is the faricimab going to work in a vitrectomized eye? Because the half-life of anti-VEGF in a vitrectomized eye is much lesser, and now this patient will require, the frequency of the injections will be much more as compared to when you have vitreous in the eye, where you can, extend your interval. So this is again an unusual case where you're guideline is not going to work and this patient needs to be on follow-up. So I just checked up on the literature, and there is one case report on where they have switched from the other anti-VEGFs to faricimab, and they found that the eye remained much stable in a vitrectomized eye when faricimab injection was given in a patient with a wet age-related macular degeneration. So the points to discuss, if we have time, is should we treat at the subclinical stage? Should vitrectomy have been done after the 3 or 4 loading doses? And after vitrectomy, like I said, at what frequent interval anti-VEGF injections should be given? So that's the first case. Now we go on to case 2. So this was a very learning case for me. So this was a 75-year-old male, decreased vision right eye for 2 months, hypertensive, no trauma or any previous surgery, no pain, redness or any similar episodes. There was no congestion. He had an immature cataract in the right eye. So the vision was only counting fingers close to face, no cells or flare, immature cataract like I showed you, and no, everything else was okay. But when you go to the fundus, you can see this whitish lesion at the just at the area of the inferior arcade there, and there was presence of subretinal fluid, and you can see the large retinal detachment involving the fovea there, along with that whitish lesion what you see at the inferior arcade. Now when you do the OCT, you can see the presence of the retinal detachment, and when you do a line scan through the area of the lesion, you see somewhat like a retina being incarcerated. That's the lesion what you see attached under the, just above the choroid, and the retina also seems incarcerated over there, and then you have some sort of few cells or a vitreous condensation what you see. And when you do the complete raster, you get the, you're also able to see there's a break over there, and along with that, that lesion is seen in this video OCT. So yeah, so that's the retinal break. So the detachment was because of the retinal break, what you see there, and so we ran an FFA and ICG for him, but unfortunately, only in the late phase of the FFA, there was extensive leakage. The late of the ICG did not reveal anything. So we did a Uvea workup for him, got a physician fitness. So he had a break, so he will require vitreoretinal surgery to settle the detachment. So we did 3-port vitrectomy, completely cleared off the vitreous, and then you can see that lesion over there at the inferior arcade, and then the vitreous was attached to it. So we carefully truncated the vitreous from the lesion, and you can see that ERM kind of a thing which is there on top of the lesion, and then that's been stripped off, and whatever is there is underneath the retina what you see. So after putting PFCL, we did off the ILM peeling. I made enlarged the retina. I made a retinectomy in that area after cauterizing. And now you can see that white lesion over there, the surface of which I have cauterized after doing the retinectomy, and then slowly I remove the lesion with the forceps. So I have absolutely no clue what I am doing over there and what this lesion is. So I just straight away just remove this from the retinal surface. So you can see just comes off the choroid over there smoothly, and then I just take it out through the, after enlarging the probe and give it, send it for biopsy. So, and then I laser, and then I settle the case with silicone oil. So the histopathology report was not very conclusive. It just said retinal tissue with fibrosis, chronic inflammatory cells, uveal pigments. So not a very conclusive report. I expected to, see something major. But then the patient walks back in to the OPD, and then now you can see that there is a huge retinitis lesion just adjacent to that break which I had made during the surgery. And then this is the OCT through the fovea. The fovea is fine, but then there is a retinitis lesion which you can see as a whitening of the inner retinal layers of what you see there. So then I just revisited the history and the investigations, and I find that we have not done a toxoplasma toxoplasma titers, and his titers were elevated 58 units, and so this was a toxoplasma retinochoroiditis, and the RD was secondary to the toxo. So we then treated, now we had to treat him, the oil is also inside the eye, so we aggressively treated with azithromycin, trimethoprim, sulfamethoxazole and prednisolone, Bactrim DS. And after treatment of 2 months and after silicone oil removal, his vision is 636 with a large scar just inferior to the arcade, and the OCT showed a foveal thinning. So probably if I had diagnosed it earlier, probably I would have able to spare much better vision. So this was a learning for me. I went back and read the literature. So tears and RD in toxo can happen, but it's rare and it's inflammatory driven, and it's a delayed onset is possible. So they need to even have a vigilant follow-up even after an active inflammation. Anatomical success rates are good, and to early intervene in such patients is the key. So thank you for your listening.